Anthony, you can commence now. It's 12 o'clock.
Okay,
And the
thanks.
floor is yours.
Right. Thanks, Sejal. Look, hello, it's Anthony Brown. I'm the Executive Director here at Health Consumers New South Wales, and I'd like very much to welcome you all to our teleconference, our webinar here today around partnering with consumers and the new standards from the Australian Commission on Safety and Quality in Healthcare. Before I start, I would like to acknowledge that this teleconference is being held across Australia. There's people joining us from all over the country, and we're all part of and standing on Aboriginal land, and I particularly pay my respects to the Gadigal people of the Eora Nation, because that's where our office is based and where this teleconference is coming to you from. And I also pay my respects to any Aboriginal people who are present and to elders past and present. And I also pay my respects to all the health consumers and health consumer representatives who are online today. We have a number of consumer representatives, and thank you and welcome, because this is all about partnering with consumers, so it's great that so many people could join us. Before I introduce our guest speaker, I would just like to run through what's going to happen today and how things will work. During the course of the conversation today, your mics will be muted. So, if people do have questions, then you'll see on the screen where there's a spot where people can type in any questions or comments as we go along. Yes, and you can see there was just a little pop-up to show where people can type in. If you're listening to this through your computer, then please select speakers and mics. And there's some people who's not able to get audio, so we might just type up the instructions there. If you are listening on the telephone, then please turn off the mics and speakers and click telephone. And if you're having trouble hearing us, then you can dial in on the telephone number that was provided in the email. So what we might do now is transfer over to Nicola. Dr. Nicola Dunbar is the Director of Strategy and Development with the Australian Commission on Safety and Quality in Healthcare. And Nicola and her team have been the group at the Commission working on this new version of the standards. So I'll hand over to Nicola now, and then we'll come back to questions at the end. So over to you, Nicola. Thank you.
Great. Thank you, Anthony. I'm just getting the IT stuff happening with the slides. Just give me a second, and then we can get stuck in. Okay, so thank you for the opportunity, Anthony and Health Consumers New South Wales, to talk to you today and talk to people today about the new version of the standard, but particularly about partnering with consumers and how it is the changes that have been made in the new version of the standards that's out for consultation. What I want to do is to give you an overview of the review process regarding the safety and quality standards, give a high-level sense of the changes with those, go into more detail about the changes with the partnering with consumer standard, and also just highlight the changes that are relevant across some of the other standards, and then at the end let you know how you can provide feedback if you're not aware of that process. So let's get stuck into that. Sorry, here we go. This slide here, sorry, I've just missed a slide. There we go. The process for reviewing the standards started actually about a year ago. We first started to pull apart the standards, look at the information that we had from the accreditation process over the previous 2 years. So we'd had 2 years worth of data from kind of beginning of 2013 into towards the end of 2014, starting to talk to our stakeholders, so consumers, people out in the system who are putting this stuff in place, clinicians working in the field, the technical groups that have been involved in different standards have all been part of this process. We've looked at the changes. So the standards themselves, the first version of the standards were developed back in 2008, 2009, 2010. So there have been changes, quite a lot of changes in terms of the environment and changes in evidence about what kind of strategies are important, what kind of issues and strategies are important around safety and quality. And we also looked at the work that the Commission has been doing since that time. People might be aware of the work that we've done about cognitive impairment, about end-of-life care, about health literacy. So we were looking at that and thinking about what do we need to pick up from this to include in the next version of the standard. So all of that stuff went into the mix in terms of the draft. So what we picked up and put into the draft of the version that's currently out for consultation. So where we're at with that in terms of the time frame, so this diagram kind of maps out the timing of where we're at. So you can see that we're currently here September 2015. It's in the middle of the consultation and the piloting process. So we've been doing this kind of feedback from stakeholders, drafting, reviewing. Lots of people have been looking at the draft that went out for consultation over the last 6 months or so. And so all of that's been going on to give you the version that you've got now. We'll be doing this over the next few months and then looking at all of the feedback that we get. I'm sure that we got a lot of feedback first time around with the standards, but I'm sure we'll get even more this time as people are used to them, know what they kind of mean from their perspective, and really want to, you know, have their say about it, which is fantastic. So we'll be looking at all of that. We anticipate making lots of changes for the final version 2, and that'll be happening end of this year into the first part of next year. And we'll be looking at going to health ministers. We need to go to health ministers again to get these endorsed around the middle of next year. There's other things that will be going on at the same time as that. One of the things that we needed to do last time and that we need to do again is probably a government thing, a Commonwealth government thing called a regulatory impact statement. Because the standards are mandatory, we need to look at the kind of burden that adds to people in terms of needing to do this mandatory action. So that's something that we will be working on through the first half of next year as well. In addition to the standards, we will also be looking at the accreditation scheme. So over the last 12 months, we've been getting feedback about the accreditation scheme and how that works. And we'll be looking at that scheme and making sure that it aligns so that when everything's ready, kind of in 2017-18, the scheme and the standards line up and we can, you know, iron out the issues that have arisen. We're aware of a lot of issues that have arisen in that process. What we'll also be doing, we're kind of starting now for some things, but we're working through the next 12 to 18 months, is looking at all the resources. So when we change the standards, we need to change all of the supporting resources that go with them. And for some of the new things, we will be writing new ones. So that'll be happening starting kind of now, working through next year, finalising all of those late next year into the following year. We'll also be looking at around what kind of training and education is needed about the new version of the standards. We do a lot of work with accrediting agencies, and so that will be something that's happening as well, to look at the development and training around here's a new set of standards, this is what it means, and that will be going on kind of in 2017. So we feel like we've done a lot of work, and we have, but we're really only partway through the process. So the high-level changes. So these are the high-level things across all of the standards. We've reduced a lot of duplication. We had a lot of feedback around the duplication in the first version of the standards, and I think we've tried very hard to to streamline that, and again the actions being more streamlined, trying to get rid of that duplication so you're not having to do things more than once or demonstrate evidence more than once. It's kind of all being brought together. In the current version of the standards, we had items and actions, and we found that there was some confusion about that, like what's in an item, what does that actually mean? Sometimes there would be a bit of a disconnect between the item and the action. And so where we're at now is we felt that it was useful to have that kind of signposting within each criteria about what things are the topics of the different actions. So we've really just changed the items to headings, and the key focus now is the actions, and it's much clearer about what we need to focus on. And I guess linked in with that is we've tried to make the actions themselves clearer, trying to put it in the active voice. If you look at it, the current version of the standards, it's kind of this will happen, or there is a system for this. It's not clear about who is responsible for doing what, and it looks like there are lots of changes because we've changed all of the actions to make it really clear about who needs to be responsible. For many cases the intent is the same, it's just been made clearer about who's doing what. And then we've got some of getting into the content changes. So we've got two new standards, one about what we're calling currently comprehensive care, which is picking up on issues around screening and assessment, looking at the patient as a whole really, and getting a sense of what is it that this person needs, and developing the care plan around that and putting that care plan in place. So that's one new standard. Then the second one we're currently calling reducing harm, but again we're open to feedback around the titles of these, and that picks up on a lot of those specific things. So we see the comprehensive care standards being a standard that applies to everybody no matter what, and then the reducing harm is around, well, if you identify in your screening and assessment that people have particular issues or particular risks of harm, then you'd need to do some specific things, and that's all incorporated into that reducing harm standard, things like falls, pressure injuries, malnutrition. I'll talk about some of those new things in a sec. 3 standards have been removed, so we've picked up the key parts of the patient ID standard and put that into communicating for safety. There was a lot of duplication within that patient identification standard, both within the standard itself and also with other standards. So it's been streamlined and linked with the communication standard. And we've also, as I said, we've picked up on the key issues around pressure injuries and falls and put that into the reducing harm standard. Again, there was a lot of duplication between those 2 standards about those processes of screening and assessment and putting a care plan in place that have been picked up and put into the comprehensive care standard. And one of the things that we've struggled with most is this issue about numbers and letters, and it's been one of the things that I've got feedback. Sorry, I'm just getting feedback. I need to change the display settings. Okay, I can't. I'm just going to keep going if that's okay. Let me see if I can do that over here. If you're not getting the right thing. I hope that, can people tell me if that's now right? We've changed the letters. Okay, good. We've changed the letters, the numbers to letters. The reason that we did that is because we've moved some of the standards out, and the ones that we wanted to put in most logically flowed up the top, most logically sat up the top. And so rather than renumbering things, we have changed the letters. We've got feedback that that doesn't work, and we've had lots of conversations internally about it. So we're very much open to feedback about that, and we may well change back. We just thought we'd put it out there and see what the world thought. Okay, so what I'm going to, so these are the standards as they are in the new version, and you'll see we've also streamlined some of the headings. But basically governance is the same, partnering with consumers. Then we've put the 2 new ones in because we thought that in the flow of what was important for everybody, irrespective of setting, the comprehensive care standard really sat as something that was really an all-encompassing type of standard, and it links very strongly with the reducing harm standard. And communication logically flowed after that. And then you get down into some of the more specific technical issues around infections, medication safety, recognising and responding to deterioration and blood. So they're the list as they stand at the moment, but as I've been saying, very much open for feedback around that. Okay, so the new things we've picked up, as I've said, we've been looking at the evidence around safety and quality, looking at a lot of the work that the Commission's been doing, and there are some new issues that have been included in the standards. These are some of them. So we've got a stronger focus on leadership in the governance standard. We realised when we looked at them again that that was something that we know is very important about safety and quality, but we didn't really have it explicit in the previous version of the standard. So we've tried to be much more explicit about what the roles of leaders are at various levels. So it's not just your kind of board level or your executives, it's both of those, but it's also that clinical leadership and what is their role around making sure people get safe and high quality care. We've picked up some issues around the environment within the organisation and making sure the environment is appropriate for safety and quality. And so that's also in the governance standard. The next 3 points around collaboration and teamwork, integrated clinical assessment and goal-directed care planning are some of the new issues that are in the comprehensive care standards, and they're picking up on some things that were already there but expanding those out into more generic things across the board for every person who's getting health care. Some of the next ones, malnutrition and dehydration, is something that's been raised with us quite a few times as a safety and quality issue. We've done a lot of work about cognitive impairment and the specific safety and quality risks that people with cognitive impairment face. Similarly, for people at the end of life and people with mental illness, there are specific safety and quality risks. So a lot of that is being picked up. Some of that's reflected in the reducing harm standard, but also in a number of other places across the standards. We've also been doing quite a bit of work around Indigenous health. So we're doing a project at the moment around how can the safety and quality standards be used to improve the care of Aboriginal people in mainstream health services. And that work has identified a number of specific things that we thought were important to include in the standards. So there's a number of actions in a couple of different places around Indigenous health. And so they're things that are within the standards, not necessarily about partnering with consumers, but then we also have some new areas about partnering with consumers around health literacy and about partnering with people and consumers in their own care. And so we'll go on and start to explore that in a bit more detail now. So the partnering with consumer standards, the intent has changed a bit to reflect the expanded focus of the standard. We continue to have the current version of Standard 2, partnering with consumers, is about partnering with consumers, particularly around governance and organisational design. And so that focus is still there, and that is the first bullet point about an organisation where consumers are partners in planning, design, delivery, measurement, evaluation of systems and services. But then we're adding another intent about consumers are partners in their own care to the extent that they choose. So we have the criteria have changed within the standard. We've got governance systems, and I'll talk a bit about that in a sec because it's something that flows across all of the standards. Partnering with consumers in design and governance, which brings together all of that, most of what was in the current Standard 2. We've pulled out health literacy and health information as a standalone criterion, and then we've added in a new criterion about partnering with consumers in their own care. So governance systems, one of the things that people who were involved in the standards last time may recall is that the standard 1 about governance, standard 2 about partnering with consumers are designed to be overarching standards, so they flow across all of the standards. The feedback that we've had is that that hasn't worked as we had intended, that often the standards get split up and people are doing things in one area but not really thinking about what does this mean from a governance perspective and what does this mean from the perspective of partnering with consumers. And so we had again had a lot of conversations internally about how can we strengthen that, how do we actually make those links clear without adding a lot of burden. And the solution that we've come to, and again it might not be the final solution because we know that it does add actions that could be duplicative, but it was really the only way that we could see that we would actually get that, you know, really strong recognition that these things are important across the board no matter what you're doing. And so we now have within each standard an item about integrated safety and quality systems, which means that people now need to demonstrate what they're doing. How does this fit with the kind of content of the standard and around partnering with consumers and governance? So what this means from the perspective of partnering with consumers is that there now needs to be an explicit link with the governance processes, so this needs to be built into governance and that link needs to be demonstrated. The other thing that we didn't have previously is about quality improvement and the need to bring a quality improvement approach to partnering with consumers. One of the things that I've found in kind of travelling around the countryside over the last few years around this is that people are doing lots of great work about partnering with consumers, but it doesn't get evaluated, it doesn't get measured, and neither the organisation or anybody else can learn from that. And so that's why we've thought that it's actually important to bring that, you know, what is often really robust quality improvement thinking that happens across safety and quality into this area of partnering with consumers, so we can start to think about it in that way. We can start to learn about what we're doing and have that continuous improvement approach to our work about partnering with consumers. So they're now built into the standards. The next criterion is about partnering with consumers in organisational design and governance, and really what this does is it picks up the actions that are currently in Standard 2. They're streamlined. You know, one of the things I found with the current Standard 2, and I was involved in putting it together, so I'm allowed to say this, is it just is a bit of a mess. There's stuff in a whole bunch of places that you could use similar strategies for, and it is quite duplicative. So we really try to reduce that and reduce the processes that you need to think about and get really the kind of core points into the actions now in the draft of the new version 2 about partnering with consumers. We've added in an action about health literacy. We had some actions, we've added in a criterion about health literacy. We had some actions previously. 2.4.1 and 2.4.2 cover off on this topic a bit around bringing in consumers, having consumers review publications and making sure that feedback is incorporated. What we've done is to clarify what that means, and we've brought together similar kinds of actions that are in other standards. So in the current standards, we have actions in a number of standards about providing information that is clear and easy to use. We've brought that all together rather than having it all these different places. And we've also added an action about the need to tailor information to the diversity of people who use the service. And I'll talk a bit more about that diversity issue in a minute. So really what we've tried to do with this is we know about health literacy as an important safety and quality issue, and to streamline it across the standards, and also by naming it up within the standards and give it more prominence. And now we get into the new criterion. We had previously had in Standard 1, we've currently got a couple of actions about partnering with people in their own care that are kind of a bit vague and not really well articulated. And that's a little bit, we've got a couple of those in a couple of other places as well. So really what we wanted to do was to bring all that together and give it the emphasis that it deserves around having a separate criteria about partnering with people in their own care. And so there are two parts of the criteria. The first part really is about that supporting framework, particularly focusing on rights, on informed consent, capacity, having systems in place to support the identification of substitute decision makers if necessary. So they're kind of in that PC5 that are these things around what do you need, if you're going to partner with people in their own care, what kind of systems do you need to have in place to enable that to occur? And then the second part of that new criterion really picks up on that partnerships in action, so around things like shared decision making, care planning, clinicians actually working together with consumers about planning, making decisions, documenting preferences and goals. So this could be something like, you know, advanced care directives, end-of-life decision making, all of those kinds of things. So making sure that people are involved in that process to the extent that they choose to be. And this one also includes the need to have systems around identifying support people, and I'm sorry about the typo in the slide there, identifying support people and making sure they're involved in processes. It also picks up on, we know that for many people, carers are actually involved in the delivery of healthcare, you know, whether that be feeding, washing, changing dressings, all of those kinds of basic care processes. And so it's enabling that, supporting that, because there is evidence, increasing evidence, that if people are supported to be able to do that, you can get good outcomes. So how can we help that happen? Again, to the extent that people want it to. And then the last one in this criterion is about building the capacity of the workforce to partner. People may recall that we have currently got an action around providing training about partnering with consumers, and again it's a bit vague. We've incorporated across all of the standards, we've incorporated all of the training actions into the governance standard. But we did think it was important here to flag this issue about, we can't expect people to have this orientation about partnering with consumers. You know, a lot of people do. It's not necessarily as embedded as we would like, though. And so we thought that it was important to flag this about building the capacity of the workforce. And the way that you build that capacity may well vary quite a bit. I guess as with a lot of these actions, and in the current set of standards, there's no one size fits all. How you do this in a large tertiary teaching hospital is very different how you would do it in a small regional centre, in a multi-purpose service, in a day procedure service. So again, just as a general point, the standards are around setting out the actions broadly, and the strategies that you use underneath that will vary quite a bit, and we'll be having to do a lot of work around providing guidance around those strategies and how people can pick them up and use them. So I'm just going to move now to just to highlight some of the other things that are relevant to partnering with consumers across the rest of the standards. One of the ones where this is quite strong is around governance. And so I said earlier that we've emphasised leadership in the governance standards, and we also now have within that the highest level of governance needs to provide leadership about partnering with consumers. So that needs to be considered as a part of what that leadership role. Partnering with consumers is right up there at the top level to say this is important, you need to show leadership for it. Now, I mentioned before about diversity. We've added in an action, and we did toss around where that action should sit. Originally, when we were drafting, it sat within the Partnering with Consumers standard, and then we moved it quite late in the piece into the governance standard because, again, we thought it was relevant across the board and at a governance level for the health service organisation to understand the diversity of the consumers who use the service. And for those health services that serve a kind of catchment area health services, things like that, they also need to understand the local community. That understanding of the community might be less relevant in some kind of health services, for example, day procedure services that really just see the people who walk through the door. But for a lot of health services, they need to think about their broad community and what's the diversity of the people in the population. So that's now in the governance standard. I mentioned earlier that we've included some actions about in the environment in the governance standard, some new actions, and these are two examples of those that are particularly relevant around partnering with consumers. The first one picks up on some of the issues around health literacy, particularly about navigation, signage, wayfinding, and the needs for that to be clear. And then the other one is something that is also new, and we tossed around internally about what to call it. We've called it consumer-based visitation, but what it actually means, and I can understand if it doesn't make sense, it actually is about open and visiting hours. So again, a lot of work in the States about the importance of visiting, not having kind of limited fixed visiting hours, making it easier for people to have their family, have their carers with them, and evidence that you're going to get better outcomes when that occurs. So we want people to start to think about that. There's work going on around the country, particularly here in New South Wales with the CEC around this, and so we thought it was time to actually start to build that into the standards. Okay, so that's the kind of key ones around governance. The next standard that really has a strong emphasis about partnering with consumers, and these are really quite linked together. The concepts flow across both, but we have them separate because we see that partnering with consumers is something that you need to do everywhere, but this focus around comprehensive care is a kind of clinical process that has its own area. So this is the new standard about comprehensive care, and what this is focusing on is to make sure that care is based on identified goals, and the consumer's preferences and needs, considers the consumer as a whole person, so focusing on life well-being generally and that kind of clinically appropriate care. So it's really taking a holistic, goal-directed focus around that. And the most explicit links, I guess, with partnering with consumers across that standard are about developing a care plan that considers the preferences and the personal circumstances of the consumer, plus information from carers, and that clinicians work in partnership to deliver care that is based on that plan. I mean, they're just two of the high-level things that I've pulled out of that, but I think there is a lot of links between that comprehensive care standard and the work about partnering with consumers. And then in terms of the other standards, some of these things are actually the same and that we had before in the previous version. And so we've had previously about supporting people, consumers to be involved in clinical handover process, and that is in the draft version as well. One of the points that's been added is about being aware of the consumer's goals and preferences during handover, and that links to the kind of comprehensive care thinking around. You really need to have that holistic thinking, goal-directed thinking as part of the delivery of care. We've actually, just to flag, we've expanded out the scope of what's currently a clinical handover standard to be more broad, so it's not just about handover, it's about communication more broadly. And so this part of this includes a focus on where there is new critical information about the consumer that needs to be transferred both between clinicians, between organisations, but also with family members and carers. So that's now in there as well. Medication safety has a focus around providing a current medicines list to people at discharge, and then we've got a action that's currently in the recognising and responding to deterioration standard that is still there about providing people with mechanisms to directly escalate care. So that's that kind of patient escalation processes around deterioration that are also starting to be used across the country. New South Wales, Queensland, ACT all have good systems in place around this. Okay, so how to provide feedback. The consultation process is open till the end of October, and there's a whole range of ways that people can provide input. Some of you might work in organisations that are participating in the pilot. We have a piloting that's going on at the moment with hospitals involved in a range of different ways, so there's that opportunity. If you want to provide a written submission, you can. You can, email us, send us a letter, whatever, around your feedback on the standards. And there are also some surveys around the standards as well, both for health service organisations and for consumers. The address that's on the slide is the page on our website that has all of the information, so it has linked to the draft standards, but also the information about how to provide input and and access to the surveys. So just to finish up with my part, and then we'll do some questions, is we've gone through the specific changes to the Partnering with Consumer Standard. It's really expanded out, so it's not just that focus on partnering with consumers in governance process. It's really much broader now around partnering with consumers across all aspects of care. But also across all of the standards, we have a greater emphasis about that partnering with consumers as being something that is necessary for safe and high quality care. If you don't have that, you're not going to get the best possible care. We've spent quite a bit of time getting to this point, but we know that we're going to have changes, and we know that there are things that we probably haven't got right. So we want to get a lot of feedback, and we would really value the feedback that you have, no matter how big or small it is. Please give it to us, because we can't have the best possible set of standards if we don't know what's working for you or what's not working for you. We really need to have your feedback, even if it is just minor stuff about this particular action doesn't work because of X. Let us know. We'll take it all into the mix. The other thing I just wanted to flag is, as I mentioned, we will be reviewing all of our support materials, and so people who have been involved with implementing systems about the standards would be familiar with the safety and quality improvement guides, and they will all need to be updated, and we'll have to add new material around the new sections of the standards. So if there are things that you're doing or things that you're aware of or whatever that you think that'd be really good to get out into the world, please let us know, and we can include that in our guidance documents, because that's a great way of kind of sharing with everybody about some of the things that are happening. So they're my contact details. There's an email address that's on the website around the submissions, but if you have anything in particular that you want to get in touch with me about, please feel free. I'm very happy to have a conversation about things. So they are all the slides that I wanted to cover. We've got plenty of time now for questions. So I'm going to throw back to Anthony and hopefully Sir Joe will tell me what I need to do with my screen.
So can people hear me now? Yep. Look, there's been some great discussion and questions as you've gone along, and thank you so much, Nicola, for that comprehensive guide to what's happening. And if people do have questions as we go, please type them in. It's great to see the increased focus through the rest of the standards around partnering with consumers, which is something I think most of us would agree with and like to see more of. I'm going to take the sort of chair's prerogative and ask a question first, and that's a high-level question around. It's great to see the new standard around reducing harm, but I think we also need to think that the principle of reducing harm also needs to come into principles of engagement. I think my two rules that I've learned from talking to very wise and experienced consumer representatives is the two principles of engagement are to listen to consumers and to do no harm. And sometimes we're placing consumers in unsafe situations when we put them in committees where they're not prepared and where people don't have the capacity and understanding for what being engaging with consumers at that level needs. So I think there's some room, hopefully, in the engagement strategies to also include, principles of reducing harm and doing, not doing harm as well.
I mean, I think that, sorry, I just got a quick comment. I mean, I think that again, it's about the naming. We had tossed around 1 million names for that standard, and I don't think we're there yet. I think that reducing harm is something that actually is an aim across the board for all of the standards. And so just having it for one doesn't quite work. So if anybody has any bright ideas, please, I'd be very happy to have them. So I think that's one thing. I think that your point around putting consumers in situations that can be harmful or even not harmful, at least discomforting and uncomfortable and threatening, is really a good one, and something that we know is difficult for people, and we don't want that to happen. So we've tried, and I mean, the current version we have it, and we've continued it around providing education and support for consumers when they're participating as partners. I think that maybe we're not strong enough about that, and so if you think that there are things that we need to beef up around that, very happy to hear them.
Great. And one of the thanks, Nicola. We will be putting something like that in our submission. It's just there was a point of clarification that people were asking about the 3 standards that have been removed. People can only see 2 on the slides. From my notes, that was the patient identification, so standard 5, pressure injuries and falls standard. Pressure injury standard 8 and falls standard 10. Is that the 3?
Yes. So standard 5 is not there anymore. The current standard 5 about patient identification. We went through that and I kind of identified what are the key issues in that. Once you take out duplication, there wasn't much, and so we've added that as a separate criterion within the communicating for safety standard, so that seemed like the most logical place to put it. And standard 8 around pressure injury, standard 10 about falls. Again, we went through that, and a lot of the actions that are in there are really around the things about screening and care planning and assessment that are picked up in comprehensive care, and then the key things that are specifically about those are in the standard about RH. So that's where they fit.
Okay, thanks. There's also, I think, a really good point around capacity and around capacity of certain groups of consumers, the groups that were highlighted here by way of examples, people with disability, cognitive health issues, and the suggestion that there's more attention that might be needed in a discussion around capacity with those groups. And I'd also like to add, talking about capacity with marginalised groups and marginalised communities as well. It's not only something for different patient or groups, but also marginalised groups, how we look at successfully engaging with them. Is there room in the standards to encompass those issues around capacity?
Because I think it's interesting, isn't it? Because I think what we're seeing is the word capacity being used in different ways. And so the way that we've used it in a couple of the actions is around capacity, in the way that you might think about it, for example, with informed consent or capacity to participate in decisions, and I think that's one way. I think some of the issues that you're highlighting are that issues around capacity to be part, to engage with the process more broadly and engage with healthcare. And it's possible that we hadn't not picked that up as well as we could do. I think we've got some actions in here. So I'm just looking at the standards. Health service organisation involves consumers in partnerships that reflect the diversity of consumers who use the services or well relevant to the local population. But what that doesn't say is you need to think about the capacity of the groups that you want to engage and support them to participate. So I think that's a good point, and I don't think we've covered it off in the standards as strongly as we might.
Yeah, and
if I'm interpreting you correctly.
I think this is one of the areas where, and it's one of those words that means different things in different settings, but I think it's also around being fully aware of the capacity of systems and services to engage with different groups, being aware of the different needs. That's a question that's come up in the discussion, and maybe I'd be interested to know from Lynn, who asked it, if we've covered that. And I also wanted to draw attention to one of the questions around partnering with consumers and around if that's inclusive of a multidisciplinary team approach, particularly around the integrated care that you were talking about before. So, does this include...
I'm not quite sure I understand the question.
So, does partnering with consumers, is that inclusive of multidisciplinary teams who are involved in integrated care? So the examples given in primary health care with primary health care clinicians, is there room in this to take in what's happening in primary care with GPs, practice nurses and private allied health, as well as hospital-based clinicians and health services?
So that they would be part of the team? I'm a little uncertain about what's being suggested. It's not to say it's bad, but I'm just a little uncertain. I guess
maybe, I don't know if I'm explaining it well. So Michelle, if you're still online, maybe if you could just give us a quick note to let us know if I've done justice to your question. Yeah. But so maybe we might come back to that.
Okay.
And we've had a response from Lynn around the issue of capacity, and her note is that capacity should not necessarily be based on diagnosis. So, which I think that's good. A question that's just coming from Rachel is whether there will be guides about health services in the community, and I assume that's around how to interact with and engage with community.
Yeah, I mean, I think what we would do is, rather than reinvent the wheel, because there's an awful lot of stuff out there about community engagement, is, as we have done in the current Safety and Quality Improvement Guide, refer to that. If that's what it means. So yeah, we would be providing advice to people about how to do that, but I think there's a whole lot of organisations that are doing that already, so we would try and link in with what's already existing rather than reinvent the wheel around how to engage with community groups.
Because I think what's really clear is I think it's really important to define the differences between consumer and community engagement and why services should do that and what they're looking, the difference reasons you do that. And speaking of organisations that have done something along this line, I'd refer everyone to here's one we prepared earlier. Health Consumers New South Wales has put out recently a model of consumer and community engagement. It's all on our website, and actually people who are interested in looking at ways to do this, I'd really encourage you to have a look at our previous webinar that was looking at the evidence behind our model. And what's also nice and I think rather neat is that models like this are a good way to link back into what Nicola was talking about before, reminding us all that engagement is part of a quality improvement process. It's something that's nice to do, but we don't just do it because it's nice to do. It actually leads to and is part of quality improvement. I'm just aware of time, and I do have to apologise to everyone that we haven't had time to get through all the questions. We will make these questions all available to Nicola, and we've got time for one or two more. Or is there a key one that's just come up?
I think it's Michelle's following on from the what we were talking about earlier. Yes, so it's about having the whole team involved in the consumer's care. I mean, I think that's absolutely the core of what we are developing with our new standard, particularly with the comprehensive care standard, is somebody needs to have responsibility for the care of the person, but we also need to recognise that there are different health professionals who have different roles, and so that needs to be integrated and done in a coordinated, logical way. Maybe logical is not quite the right word there, but in a coordinated way, so we don't get what we know happens with different with things being siloed, with different information coming from different healthcare providers, so that it is holistic, and so that is it is definitely about having processes so that the team works together and that the team works together to deliver the kind of goal-directed care plan for the patient. So that's very much where we're heading.
Great. Thanks for that clarification, Michelle, and for that answer, Nicola. I think we are getting close to time, and again, I'm sorry that we haven't been able to get to everybody's question. There was one question that I just did want to follow up on around, and I'm sorry I don't have it in front of me now, but it's around, I think, consumer roles and people being aware of their roles as consumer representatives, and people who see their roles as just conveying complaints rather than being involved in a more positive way of giving feedback to services. And to me, that gets back to the question we were talking about before around capacity, the capacity of the people involved, and also around services being clear around what people's roles are in different ways of consulting with people. So, and I think again that the standards do offer some ways to do that, but I'd also encourage people to maybe talk to your local consumer peak in your state or territory, because there is some work being done around working with services and committees around clarifying those sort of roles. So for me, that's I think some working on the roles and capacity of both the consumers and the service there will help with that. And a question. So there has been some discussion, and I don't know if we've got scope in the few minutes left to talk about some of the ways things are being used and whether numbers are less confusing. That might be more of a process issue to deal with a bit later on, but that's been noted, and thanks to the people who have pointed that out. I think we are at a time now where it's nearly an hour, so it is time, and we will start to finish up. We'll let people know that Nicola's slides will be made available to everybody after the presentation, so they'll be available for everybody to look at. And a recording of the webinar will also be put online, will be put on the Health Consumers New South Wales website, and a link to that will be sent out to everybody, together with links again to the Commission and the ways to make a response to everything. So thanks to everybody who's been involved. Thanks for the great discussion, and again, my apologies that we haven't been able to get to all of that, but we will go through that and make those questions available to Nicola, and we'll do our best to answer them. So thank you very much.
Yeah, that'll be fine.
And if there's any sort of last words or anything that's really important that you think we need to finish on, or have we said everything that's...
No, that's all good. I think it's all good, and there are some late questions coming through, and as Anthony said, if Anthony will give them all to me, and I'm happy, I'll respond to them, so you'll get some responses.
Yeah, and look, what we'll do, as I said, we will wrap up now, and I see that there's some really interesting and important questions coming through around mental health and other ways to strengthen the engaging with consumer ideas that have been said here. When we finish, people will get a quick evaluation around today's webinar. I'd really encourage you to do that, and for people who we haven't had a chance to answer some of your important questions, please go through, and there's an opportunity there to suggest topics for future webinars. Please make note of some of these things, because I think some of these things could be, whole hour webinars in themselves. So please do that, and go on to our feedback session now. So thank you all very much. Thanks again, Nicola, and I think we might end it here, and thanks everyone for joining us.